So in our group 5, we were supposed to discuss SIADH and Diabetes Insipidus. SIADH in full is a syndrome of inappropriate ADH secretion. So these are the conditions. Okay, I'm going to give a brief we're going to know how these conditions affect our bodies or their pathogenesis in our bodies. So these two conditions, that is SIADH and diabetes insipidus, are conditions that body via ADH. As you know, ADH is the one which determines the amount of water that is being required in our body. So I'm going to give the physiology part of ADH, and after we have mastered that, I know these others will be a work of. So ADH, as you know, is being triggered by some conditions. Those conditions, they include blood volume, that is low blood volume, which is hypovolemia. And then we have a low blood pressure, that is hypotension, and even increased blood osmolality. I mean osmolality, not osmolarity. Osmolality. So these conditions, those main ones, like two of them, that is hypovolemia and increased plasma osmolality, they trigger secretion of ADH from the hypothalamus. As you know, ADH is being secreted from hypothalamus from I think it is paraventricular nuclei in the hypothalamus. Then is being stored in the posterior pituitary gland. From there, the posterior pituitary gland stores ADH. Then when the body now requires this ADH or water, is being released from there. So ADH is being transported via blood through the blood streams to the kidney in the renal collecting tubules, where it is being it is being received by receptors, that is vasopressin receptors, V2 receptors, AV receptors there by receptors. These receptors initiate they initiate or activate the cyclic adenomonophosphate signaling. Those signaling initiate the insertion of aquaporin 2 water channels, which allows water to enter the tubules. So after ADH has been initiated to enter into the bloodstream, now that is the physiology. In short, that is the physiology part of ADH, how this ADH is being taken into the bloodstreams. So let me start from SIADH. So SIADH, syndrome of inappropriate ADH secretion, is a condition where excess ADH is secreted without physiological need, leading to water retention, dilution of sodium in the blood, that is hyponatremia, and concentrated urine. So this hyponatremia is where the sodium levels in the body are low because water has been, or because the plasma has been diluted by this overproduction of water, abnormal production of water. Let's move to the next slide. So, causes. Let's look at the causes of this SIADH. Number one is nervous system disorders such as trauma, meningitis, brain tumors, and stroke. And then we have malignancies like pancreatic or prostate cancer. These malignancies, some of them through mechanism of ectopic mechanism, they are being able to secrete ADH by themselves. All these malignancies, the malignant tumors, they can initiate the hypothalamus to produce this ADH. That is why I say these malignancies, themselves, they can produce ADH, or they can initiate the hypothalamus to produce this ADH, and this leads to over absorption of water into the body. Then we have pulmonary disorders such as pneumonia, tuberculosis, and acute respiratory failure. So these TB and pneumonia, they can trigger systemic inflammation in the body, which stimulates ADH release. Then we have medications. Some medications such as carbamazepine, these NSAIDs, yeah, and so on. They can initiate the oversecretion of this ADH, which leads to more absorption of water in the body. Let's move to the next slide. Pathophysiology. Let's look. Okay, we already have covered the pathophysiology of these two conditions, but let's look specifically on SIADH. So excess ADH secretion occurs independent of normal feedback. That is not due to low blood volume or high plasma osmolarity. As I said, um, ADH is being stimulated by these conditions, like conditions like low blood volume, that is hypovolemia, even stress, trauma, things of such kind. So excess ADH is being secreted regardless of the volume of blood that is present in the body. ADH is overproduced. Then number two, ADH acts on V2 receptors, that is vasopressin receptors in the renal collecting ducts, causing insertion of aquaporin 2 channels, increasing water reabsorption. That is the physiology part of it. So water is reabsorbed into bloodstream, but sodium is not. Simply because, like, when you look at the cell, the cells doesn't allow. Okay, the cell has this property of specificity. So water enters into the cell, but the sodium concentration in plasma increases because water have been absorbed into those cells. And we are going to see the absorption of water into these cells, like in brain cells. It causes confusion and headaches. So water is being reabsorbed into the body. Yeah, that one. So total body water increases, but extracellular fluid volume expansion is merely limited due to escape mechanisms like natriuresis, suppressed aldosterone, and increased AMP. Okay, these terms you can search them so that you may know them, but already explained the physiology of the absorption of ADH. So that we're going to understand it when we're going to know these things like A and P and B and P. So urine remains concentrated and dilute. So as you know, serum is just in the blood, except, okay, serum consists of those components, other components except the blood clotting factors like fibrogen. So serum becomes dilute and the urine remains concentrated. Why urine remains concentrated is because what has been reabsorbed from the urine tubules has been reabsorbed into bloodstream, so there is less volume or amount of urine, but its concentration increases because of. Okay, let's continue. Let's go to the next slide. We have signs and symptoms of this SIADH. Symptoms mainly arise from hyponatremia and brain cell swelling. Yeah, then mild to moderate hyponatremia, that is a sodium levels. We have normal sodium concentration in the body. When this sodium concentration in the body increases, this indicates that a lot of water is being reabsorbed into the cells. And and confusion, such things, I said earlier, for example, in the brain cells, water is being reabsorbed into the brain cells, causing this headache. So si kichwa yote inakuuma alafu nasema probably ni vitu zingine, lakini hii SIADH pia inaweza kuwa. Let's continue. So we have severe hyponatremia, that is more than 125. Then we have confusion, seizures, coma, and death. Then these seizures, I can explain briefly on these seizures. Seizures is the abnormal electrical conductivity in the brain cells. Okay, for example, you can get maybe you are in a place, you are seated, then somebody suddenly is looking at you without even blinking maybe his or her eyes, like anakuangalia tu, then all of a sudden that person collapses. Maybe that condition may be seizures because of the abnormal electrical or inappropriate electrical conductivity in the brain. Let's continue. So we have diagnosis of SIADH. Then we have test and the typical result. So serum sodium is decreased, that is hyponatremia, than normal. You see normal there is 135. Serum osmolality also decreases. Urine osmolality increases because of urine is now concentrated. Then you have urine sodium also increases. Then serum or urea, serum urea or uric acid becomes low. Let's continue. So there is a criteria that is being used to diagnose this SIADH, that is hypotonic hyponatremia. These things I've already explained them, like hyponatremia. That is the hypertonic is blood pressure, and hyponatremia is the low concentration of sodium levels. Okay, so euvolemia is just the normal blood volume. Okay, normal blood volume, that is euvolemia. We have hypovolemia, that is low blood volume. Then you have euvolemia, then hypervolemia. Then next point is an inappropriately concentrated urine that shows SIADH. Normal adrenal, thyroid, adrenal, and cardiac function. Then we have no recent diuretic use. There is a criteria that is being used to diagnose this condition, SIADH. Let's move the next slide. Okay, I think we have understood all SIADH. Let's move to diabetes insipidus. So there is a disorder that is characterized by inability of the body to retain water due to either a deficiency of ADH or renal resistance. Okay, this DI is simply the opposite. You can say it is opposite of SIADH, because SIADH is overproduction of ADH leading to water retention. Then diabetes insipidus is low, inefficient ADH based on the type of diabetes insipidus, because we have several types of diabetes insipidus. So this leads to production of large amounts of dilute urine because the renal tubules are not able to absorb water into the bloodstream. So the urine amount of volume increases, then the concentration reduces. In short, it is just the opposite of SIADH. Let's move to the next slide. Let's continue. We have causes of this, that is etiology. We have causes of the eye. Okay, these causes are based on the type of the eye. We have 4 types of the eye, but the ones that we have indicated in the slides are 2 because they are major ones. We have central the eye, then we have a nephrogenic the eye. So central the eye is a decreased production or secretion of ADH from the hypothalamus or posterior pituitary gland, but hypothalamus is the one which secretes ADH, and pituitary gland, this posterior pituitary gland, is the one which stores and then releases this ADH. So causes of central DI, we have things like head trauma, brain tumors, neurosurgery, infections, and idiopathic. Okay, these conditions, you can read them maybe individually so that you can relate on how they cause decreased production of ADH. Because of time, let me move to the next slide. We have nephrogenic DI. Nephrogenic DI, this is where kidneys are resistant to ADH, so they can't respond properly. Like ADH in the body is being produced normally, but the kidney tubules, they are not able to respond to this ADH, meaning there is obstruction or disorientation of there's mechanisms like V2 receptors, okay, V2 receptors, aquaporin, insertion of aquaporin 2 channels. There is a problem there that causes the kidney not able to absorb this water because ADH is present. So we have causes of this nephrogenic DI. Congenital causes, we have mutation in ADH receptor or aquaporin 2 channel. That is what I've talked about already. Then acquired, these are the conditions that maybe you get them, okay? They develop, like drugs. We have certain drugs that cause this nephrogenic DI, like lithium. We have chronic kidney disease. We have hypercalcemia or hyperkalemia. Then you have post-obstructive uropathy. These are some of the conditions. Maybe you can study them and know them, how they cause this nephrogenic DI. Then other types, the two remaining, they are trypsogenic DI and Yesterday I with the gestational DI, and our lecturer told about vasopressinase, and this vasopressinase breaks down ADH. That is all about gestational DI. Then trypsogenic is where excessive water intake due to abnormal thirst mechanism. Like unakuanga na kiu tu na take a lot of fluids into the body. That is dipsogenic DI due to obstruction of that center. Yeah, I don't know if this is the last slide. Okay, pathophysiology. Pathophysiology of DI, it is just the reverse of SIADH. Okay, so let's go through them very fast because of time. We have normal function of ADH. Normal function of ADH, I already explained how this ADH is being produced, is being inserted, or the mechanism of this ADH causing water absorption. Yeah, ADH is released from the posterior pituitary gland, acts on. Let's move the next slide because already I've talked about this. Okay, so we have this process specifically on the type of DI, like in central DI. Central DI, it is where there is damage or dysfunction of the hypothalamus or posterior pituitary gland to secrete ADH. Then without ADH, as you know, kidneys cannot absorb water in the collecting tubules. As a result of that, water is being lost in the urine, leading to, okay, hapa sasa kwa urine, leading to polyuria. There is large volume of dilute urine. Then polydipsia, that is excess thirst. Kwa urine, you have to note the amount of urine that you produce, or a patient suffering from this central DI produces. Like in urine, there is increased volume or amount of urine, then concentration of urine is less. Okay, let's move the next slide. In nephrogenic, ADH is produced and secreted. As we said, nephrogenic is where the kidney produced and secreted normally by hypothalamus, reaches the kidney and binds to V2 receptors in the collecting ducts. Then these receptors, V2 receptors, okay, so they are channels, they fail to respond. though ADH has been produced normally. As a result, absorption is impaired. Next slide. This leads to excretion of large volumes of dilute urine, that is polyuria. The body loses free water, causing dehydration and increased serum osmolality, hypernatremia, because the sodium ions that are present in plasma are being overdiluted. Okay, the patient develops intense thirst to try, yeah, thirst. Kawaida tu thirst lazima mgonjwa akuwe na. Next, imeisha. We have signs and symptoms. So we are going to, okay, general signs. We have polyuria, excessive urination. We have polydipsia, excessive thirst, and then we have nocturia, frequent urination at night. Like urination at night, I don't know the normal. Maybe mtu unafaa kuenda hiyo nini mara moja, lakini sasa unapata kama mtu anaenda mara 5 hivi ama mara 3. Sasa hapa kuna shida. Let's continue. That is nocturia. Diagnosis. We have the test and typical finding. Serum sodium inakaa increased like more than normal. Serum osmolality increased also. Urine osmolality decreased. Urine specific gravity decreased. We have normals of these things. So probably LEC can tell us if these things are essential, necessary for now, for us to master the initial, like the normals, because hizi normals pia mimi zinakuanga ngumu kuzishika. Sa I don't know kama ameziset ku exam atuambia at least tushike, but if they are necessary for now, we can just know increases and decreases. Urine volume,
they are very essential.
they are
very
essential. Okay.
They are very
So we can
essential.
master. Okay,
But
we can
with time
master
you
them.
get to understand them, yes.
Okay. So as he has told us, we can master them. Yeah, the normals of this serum sodium, serum osmolality, urine osmolality. I think is the end of the presentation, and that is thank you.
Thank you. I think that was very well elaborated. Diabetes insipidus and also syndrome of inappropriate antidiuretic hormone, the eyes and then by the posterior pituitary gland. So 2 main types: diabetes, central diabetes insipidus, or the neurogenic, which is caused by antidiuretic hormone production or release as a result of damage to the hypothalamus, which leads now to decreased or absent antidiuretic hormone secretion. And if we have decreased or absent ADH secretion, then now the kidneys will not be able to reabsorb water in the collecting ducts, and that will now lead to excretion of large volumes of dilute urine, which now manifests in the when she talked about the polyuria and also increased thirst, the polydipsia. Then the nephrogenic diabetes insipidus, when the kidneys are unresponsive to ADH, that despite now normal the renal collecting ducts do not now respond to the hormone, and that's going to be mostly caused by either genetic mutations, those with chronic kidney diseases, those with electrolyte imbalances like the hypercalcemia, hypokalemia, or use of some, and that means now that if the kidneys are unresponsive to ADH, then again water reabsorption is impaired, and that's going to lead to polydipsia, polyuria that we're talking about. Of course, the common outcomes for all types of the diabetes insipidus, there'll be inability to concentrate the urine, large urine output, the polyuria, increased thirst, polydipsia, risk for dehydration, hypernatremia because of water hypovolemia, if fluid intake will be inadequate. Then for syndrome, antidiuretic hormone. Now, that is the opposite of DI, where there's now excessive secretion or action of the ADH, which now leads to water retention, hyponatremia, and also serum osmolarity. So basically, the SIADH will be the direct opposite of now what we'll have in diabetes insipidus.